Hey everybody, and welcome to another video. Today we're going to be talking about the nebulous and sometimes challenging diagnosis of nephrotic syndrome. Quick channel plug, this is a channel Whiteboard Doctor. It's an open access medical education YouTube channel hoping to bring you interesting and relevant medical education topics. Couple channel plugs and shoutouts. Number one, we have this fun subscribe button in the bottom right hand corner. If you like what you see and you want to follow along, please feel free to hit that. We appreciate you. Number two, we're part of Patreon. If you feel inclined and want to support this channel in additional ways, or just check out our Patreon page, it is linked in this video's description. Number three, we're also part of a website called Buy Me a Cup of Coffee. It's meant for creators where you can go and give us, quote unquote, tips to buy us a cup of coffee if you like what you're seeing. That is also linked in the video description. Number four, we are part of YouTube membership. You can go to our channel page and click join if you want to follow along and become a member of the Whiteboard Doctor community. All right, nephrotic syndrome. So what we're going to talk about in this video is we're going to start actually with the clinical findings of nephrotic syndrome. The reason we're going to do that is because those clinical findings are directly related to the pathophysiology. So we're going to start with the clinical findings, then we're going to explain each one of those by using the pathophysiology that causes them so that we can better understand the disease process and better remember what those clinical findings are. We will then relate those clinical findings to the workup that you should do, the complications that can result from nephrotic syndrome. We'll go into the major causes and then briefly touch on treatment. So starting with clinical findings first, the clinical findings in nephrotic syndrome are kind of multiple folds. I do just want to mention we will be doing a video on nephritic syndrome as well, and then a video differentiating nephrotic from nephritic syndrome. So keep those in mind if this is a topic that's you want to follow along and want to learn more about. So the biggest thing in nephrotic syndrome is we get this severe proteinuria. Proteinuria is protein in the urine. And the severe proteinuria in nephrotic syndrome tends to be greater than 3.5 grams of protein per day in 24 hours. And this sometimes relates on the urinalysis or dipstick to 3 plus or 4 plus, but it is not as sensitive, so you really want a 24-hour protein. Number two, we will see venous thromboembolism, or VTE, blood clots, DVTs, and PEs, and we're going to talk about why we see those things. Number three, we tend to see edema, or swelling in the soft tissues, such as the legs. Four, we tend to see hyperlipidemia, elevated fats in the blood, such as cholesterol, so hyperlipidemia. Five, we see hypocalcemia, which is low calcium in the blood. All right, and six, we tend to see infection. So why do we see these clinical findings is a question about the pathophysiology. So what exactly happens in nephrotic syndrome? So we're going to zoom in here, and I'm going to scroll down a little bit, and we're going to talk about our little friend here. So this is a drawing. We're very artistic, as some of you who have been following this channel know. And what we have here, we have the lungs. As hopefully you guessed, we have the heart. Down here we have these bean-shaped organs, which are the kidneys, and they're going to be the star of the show. That says kidneys. This here is the liver, with another kidney sitting behind it. And then here we have the aorta, the big blood vessel, aorta, that feeds blood to the body, and the inferior vena cava, or the IVC, which takes venous blood back to the heart. We're going to use these structures to discuss the different findings. The first thing, though, that we want to discuss is the severe proteinuria, number one. So to do that, we're going to, take a chunk out of the kidney, and we're going to zoom in on that chunk. Doing so will show us kind of a single functional unit of the kidney, or a nephron. And this nephron has the blood vessel, an efferent going in, all right, and an afferent, and the afferent is taking blood away. And when we say in and away, we're talking about to the glomerulus, which is right here. And the glomerulus is surrounded by something called Bowman's capsule. And what the glomerulus is it's a bunch of thin capillary blood vessels all kind of looped together that allows fluid to leak from the blood vessels into Bowman's capsule. What happens once it's in Bowman's capsule? Well, once it's in Bowman's capsule, it's collected into the nephron itself. And the nephron has multiple kind of different areas, which we're going to talk about. And we're going to draw here. All right, so what we have here is the proximal convoluted tubule. It goes into thick descending, then it thins out, thick ascending, distal convoluted tubule into the collecting duct. And this is where urine is excreted. Okay, so what happens is, blood goes through the efferent into Bowman's capsule, fluids will leak out, and then it'll come back out the efferent and is drained into the venous system. So what happens exactly when there's nephrotic syndrome? Well, it's actually an injury to Bowman's, or to the glomerulus, right? It's a glomerulopathy. So to talk about that, we're actually going to zoom in again and take a chunk out of the glomerulus. So when we zoom in, what we see here when looking at a blood vessel, part of that glomerulus, is you're going to see a circle, right? And this is the inside of this blood vessel is covered with endothelial cells. And these endothelial cells have junctions between them to keep the blood inside, right? And within the lumen of the small blood vessel, we have things like red blood cells, right? In addition to that, we have proteins floating around, as one often does. If we, had an infection recently or just have a memory response, we're going to have antibodies floating around in there. And then we also have kind of coagulation cascade factors, specifically antithrombin 3. If you can see that, that's AT3, antithrombin 3. And in the glomerulus, this capillary is surrounded by what are called podocytes. Okay, what podocytes are, let's see, what color do we want to make them? We shall make them purple. What podocytes are is they're these finger-like projections that actually surround the capillary, and you see them in different cuts. Sometimes you see this big finger-like projection, sometimes they're just small cuts, and their function is that they kind of continue to form tight junctions, because what you don't want is for everything just to leak out of this capillary into the inside of kind of the Bowman's capsule proximal convoluted tubule and be excreted in the urine. You want to be selective of what can get in and out. Well, what happens in nephrotic syndrome? In nephrotic syndrome, depending on the cause of it, there's an injury to these podocytes, right? These purple things are podocytes. And these podocytes sustain an injury. And when there's an injury to them, those tight junctions, right? Those tight junctions start to get looser. So we're going to draw another one here, right? And as we see, I'm sure you can name what these are now. These are endothelial cells on the inside, right? And around them are supposed to be the podocytes. But now the podocytes, instead of forming really tight junctions, have an injury. So they're spread out more. There's leaky areas that things can leak out of. In addition to that, these tight junctions between the capillaries, between the endothelial cells, since there's no podocytes, can let things from inside the capillary go to the outside of the capillary. But the pathology is primarily in the podocytes rather than the capillary itself, because that would be more like nephritic syndrome or glomerulonephritis, which we'll talk about in a different video. So what do we see happen then? Well, what we see happen is that the things that were inside the capillary start to leak out into Bowman's capsule. So we see things leaking out like protein, immunoglobulin, which we'll just write IGs for immunoglobulins, antithrombin 3, AT3, and then you can see kind of some small red blood cells leak out too. Oh, let me mute my computer, I apologize. So where does that all leak out to? Well, we said we were zooming in on the glomerulus here. So all these things are leaking out into Bowman's capsule and then into the nephron, right? So we see all this protein leaking out. We see immunoglobulins leaking out. We see antithrombin 3 leaking out. And, a red blood cell every now and again. So then all that gets excreted into the urine, right? It all travels through the nephron, and it can't be, reabsorbed because the molecules are too big, and it's excreted into the urine. So what does that mean then? What happens? Well, if we go back to our clinical findings, all these things can be explained by the chain of reactions that occurs when we start excreting all these molecules and proteins into the urine because of the injury in the podocytes. All right, so let's go through that then. So number one, we talked about severe proteinuria. So we're going to put in number one right here. Number one. Severe proteinuria, protein in the urine, occurs because your protein leaks out of the glomerulus because of the podocyte injury into Bowman's capsule, into the nephron, and is peed out. So you get severe proteinuria. Number two, VTE, venous thromboembolism. What is venous thromboembolism? So we're going to go to our human, right? We have the top of the human, the arms, the belly, and then the blood vessels. So venous thromboembolism occurs, right, when there's a blood clot, such as a deep vein thrombosis, in the, it can be pretty much anywhere. In any of the deep veins, you get a pulmonary embolism, etc. So number two, we're going to label venous thromboembolism, blood clot here. What's happening? Well, you're losing antithrombin 3, which we talked about, right? The antithrombin 3 is leaking out into the nephron and being excreted in the urine. Well, what does that cause? If we go back to our coagulation cascade, as we all love to, we know factor 10A converts 2 into 2A, right? 2A is thrombin, and then this converts fibrinogen into fibrin, and fibrin goes over and forms a blood clot. Well, this is usually a partial negative feedback mechanism, involves antithrombin 3 here. Antithrombin 3, when it's in normal levels in the body, goes and inhibits factor 10A, negative feedback on 10A, and also factor 2A. By doing such, you can't form fibrin and you don't form blood clots. So when you lose antithrombin 3 because it's leaking out of your efferent arteriole into the glomerulus, leaking out from the podocyte injury into the nephron and being urinated out, you're not having this negative feedback loop, so you're more prone to blood clots. Okay, so number two clinical finding, venous thromboembolism is secondary to a decrease in antithrombin 3 and thus dysregulation of the coagulation cascade. All right, what do we have next on the list? Next, we have edema or swelling. So when you have edema or swelling, fluid is leaking out of the vasculature and it is leaking into the interstitium, right? So again, we have our legs here. Here's a vein and we're getting fluid leaking out into the interstitium and you're getting swelling. Well, why is that happening? To understand that, we have to go back to our pressures and what regulates the fluid in the intravascular space. So what I'm drawing here, this is going to be a vein. All right? And what leads to fluid staying in the intravascular space depends on hydrostatic and oncotic pressures. Hydrostatic pressure. Hydrostatic pressure is the intravascular pressure as compared to the extravascular pressure, right? You want those fairly even. If one is bigger than the other, if the intravascular pressure is greater than the extravascular pressure, then fluid is going to leak out of the vessel because the pressure inside is greater than the pressure outside. Well, the other thing that regulates this is oncotic pressure. So I'm just going to write here hydrostatic. All right, the other thing that regulates this is called oncotic pressure. Oncotic pressure is the pressure gradient derived from molecules, right? Things like proteins, electrolytes, all that type of thing. And this is oncotic pressure because water follows those types of molecules, right? So if you're oncotic pressure, if there's more protein and things outside the vessel, water is going to follow and leak out of the vessel into the area that has more molecules, right? In nephrotic syndrome, what did we say happens? Right? We said we're losing a bunch of protein, a bunch of albumin in the urine, right? We're getting this severe proteinemia, right? Number 1, severe proteinemia. So doing so leads to a decrease in oncotic pressure. So oncotic pressure is decreased in the intravascular space because you don't have as much protein. In addition to that, and we will get into this, you sometimes have increased hydrostatic pressure because of your renin, angiotensin, aldosterone system dysregulation. We're going to get into that a little bit later. But a decreased intravascular oncotic pressure and an increased intravascular hydrostatic pressure leads to fluid leaking out of the vascular space into the interstitium. And let's draw that a different color just because it'll be easier to keep track of. So you dysregulate your oncotic pressure and hydrostatic pressure, and you have less protein in the vessel, and you have more pressure in the vessel, so fluid flows out of the vessel into the extravascular space, leading to edema, right? So that is number 3 clinical finding, edema. All right, what do we have for 4 then? Hyperlipidemia. Why the heck should you get high cholesterol in nephrotic syndrome? Well, to understand that, we have to talk about the liver. And we drew the liver here. So we're going to take this and we're going to take it way down to the bottom here. And then we're going to just redraw the liver. All right. So here's our liver, right? And what does our liver do? So our liver regulates albumin and lipoprotein. When we start losing all of our albumin, all of our protein in the urine from our severe proteinemia, our liver says, wait, this is going to mess up the oncotic pressure, as we talked about. So to try to combat that, when the albumin decreases, the liver starts to produce more albumin, but it also starts to produce more lipoproteins, right? And lipo being fat, these are proteins involved in lipid production and lipid stabilization and lipid transport. So it starts producing more lipids. All right. It will also start producing, more albumin. But primarily, these increased lipids start to actually lead to hyperlipidemia. And just as a reminder, right, the increased lipoproteins are intended to try to increase the oncotic pressure in the vessel to decrease the amount of fluid that is leaking out of the vascular space into the interstitium. All right, that leads to elevated cholesterol or hyperlipidemia. It's the liver producing more lipoproteins to try to even out the oncotic pressure, right? So as we saw, this then would be clinical finding number 4, which if we zoom up, clinical finding number 4 is hyperlipidemia. All right. The other thing to note, which we'll come back to, is when we have increased lipoproteins and hyperlipidemia, we do get some leakage of that fat into the glomerulus as well. And we'll talk about what that means after we're done talking about the clinical findings. All right, then hypocalcemia. Why would we get hypocalcemia in nephrotic syndrome? Well, that's actually related to our liver, our severe proteinuria, and our blood vessels. So we're actually going to draw a line over here, and we're going to draw again a blood vessel. So calcium is a very positively charged particle. And albumin, which is a protein, is going to be kind of represented by this brown. Albumin is a very negatively charged particle. And typically in a normal state, our calcium, a huge majority of it, is bonded with our albumin because calcium is so positively charged. And the albumin helps carry around the calcium. So when we look at hypocalcemia clinically, if a patient is hypocalcemic, often what we'll do is we'll look at their albumin. And if their albumin's low, there's a correction you can do to correct for the hypocalcemia. Well, as we said, right, we said that we get this severe proteinemia. We lose all of our albumin and our protein in the urine. So when we do that, we no longer have this negatively charged albumin to carry around calcium, and we start to then get dysregulation of our calcium homeostasis. So we start losing calcium and get decreased calcium levels because of the decreased albumin levels. All right, and that's how we get what number are we on? Number 5, hypocalcemia. All right, last but not least, infection, number 6. Well, if you were listening early on and paying close attention, we mentioned that in addition to protein and antithrombin 3, we also start to lose immunoglobulins. These immunoglobulins, when the podocytes get injured, leak out of the intravascular glomerular space and they're excreted in the urine. Well, because of that, we have a relative immunodeficiency. So what happens is that we then can start to get infections in places like the lungs. We can get a consolidation and a pneumonia. And this consolidation and pneumonia is secondary to the relative immunodeficiency that occurs, with decreased immunoglobulin levels because they've all been urinated out. And that is number 6. So let's zoom out now and just kind of take a look at what we've put together so far. So we have these clinical findings. Let's zoom in one more. Of severe proteinuria, venous thromboembolism, edema, hyperlipidemia, hypocalcemia, and infection. And we've talked about why each one happens. So in nephrotic syndrome, get an injury of the podocytes. The podocytes are finger-like projections that wrap around the glomerulus. When those podocytes are injured, things from within the glomerulus that usually would just stay intravascularly, go into the afferent, and then be in the venous system and not end up in the nephron, start to leak out of the glomerulus. Things like protein causing severe proteinuria, things like antithrombin 3 leading to venous thromboembolism as your coagulation cascade is dysregulated. Things like albumin, right, that lead to a decreased oncotic pressure and then leading to edema. Things like hyperlipidemia occurring in our liver by increased production of lipoproteins to try to make up for that decreased oncotic pressure from all the albumin lost. Hypocalcemia, as we lose albumin, one of the negatively charged proteins that carries calcium. And infection, as we lose immunoglobulin, leading to a relative immunodeficiency. Okay, so now that we've connected the clinical findings in nephrotic syndrome to the pathophysiology, what should we do when we're concerned for nephrotic syndrome? How do we work up nephrotic syndrome, and how do we diagnose it? Well, all that is actually related to the clinical findings in the pathophysiology, right? So the workup for nephrotic syndrome is going to involve a few things, all right? One of those things is going to be urine studies, specifically a urinalysis. A urinalysis is going to tell us if there's blood, if there's protein, if there's infection. And in this case specifically, we're looking for protein, right? You want that severe proteinuria. And if you're doing a 24-hour, it should be greater than 3.5 grams per day. If you're doing a dipstick, you can use the kind of 3+ or 4+ protein, but it is not as good as if you do a 24-hour urine collection. In addition to that, we're going to want urine sediment to look for casts. Casts occur when in the nephron, you start to get a buildup of a material that kind of clumps together and then is urinated out as a clump. Now, these are microscopic. You can see them in the microscope. You can't look in your urine and see them. But what we tend to see are severalfold. One, we're going to see what we call waxy casts. Waxy casts are from protein. Why do we see waxy casts in nephrotic syndrome? Because we're losing all this protein in the urine, so you get protein clumps that form waxy casts. In addition to that, we're going to see fatty casts. Remember how I said that we're going to urinate out a bunch of fat because our liver is increasing the production of those lipoproteins, some of which get in the urine. We start to see fatty casts because of that liver's overproduction of lipoproteins. And then you might see a few red blood cells, but this should not be the predominant finding. Otherwise, that might imply that there's also glomerular nephritis or nephritic syndrome occurring. Okay, beyond urine, we also want some lab work. We're going to want a basic metabolic panel, a magnesium, a phosphorus, and a calcium. Why do we want those things? Well, the basic metabolic panel will give us an indication if we could be developing an acute kidney injury from the nephrotic syndrome. This does not always happen, but it does sometimes happen. As we injure our glomerulus, right, what's going to happen is we're going to have more things leaking into the nephron, and that'll cause less blood to flow out the afferent. When less blood flows out the afferent, we get a dysregulation of our RAS system, renin, angiotensin, aldosterone system. And that dysregulated RAS system leads to afferent dysregulation, afferent and efferent arterial changes that can decrease blood flow to the glomerulus, leading to an acute kidney injury. Okay, in addition to the acute kidney injury, we zoom back out, see if we can get our whole picture again. In addition to the acute kidney injury, we want to send these because, as we mentioned, we can develop electrolyte abnormalities, including hypocalcemia, especially if they have an acute kidney injury. In addition to that, we do want to send a serum albumin, right? Albumin's a protein, and albumin in nephrotic syndrome, the serum albumin will typically be low because you're urinating so much of it out. And then lastly, which relates to kind of the diagnosis of it, we tend to want to send a hepatitis B, a hepatitis C, HIV, ANA, double-stranded DNA, and eventually you most likely will need a renal biopsy to look at the tissue under the microscope. And the reason that we need these things relates to, as I mentioned, the cause. So this lecture, we're not going to go into detail on the causes, but I do just want to mention a handful of the causes. And major causes for this include things like minimal change disease, all right, focal glomerular sclerosis, FGS, membranous nephropathy, and we'll talk about these in future videos. So keep your eyes peeled, subscribe if you want to follow along. And these are called primary causes, right? In addition to that, you can get secondary causes as well from things like diabetes, SLE, systemic lupus, viral causes, hence the hepatitis panels. The SLE, right, we're sending double-stranded DNA and ANA for SLE. Viral infections amyloid can cause this. And actually preeclampsia as well. And there's more, but these are kind of just the major causes. So there's primary and secondary causes as well. All right. So I hope that was helpful. I know nephrotic syndrome is complex and there's a lot going on, but if you think of these clinical findings and you remember them as related to the pathophysiology that's going on, I think that helps in remembering exactly what you need to do then to work up and diagnose it, because all these things are interrelated. All right, so in summary, nephrotic syndrome is an injury to the podocytes. The podocytes are finger-like projections that surround the capillaries in the glomerulus. When those podocytes are injured, things from inside the capillaries start to leak out of the capillaries into Bowman's capsule and start to be excreted in the urine. Because of that, you get severe proteinuria, protein in the urine. You leak out antithrombin 3, so you're more prone to blood clots, as antithrombin 3 usually inhibits factor 10A and thrombin. So without that, you get more fibrin production and more blood clotting. You also get edema as your oncotic pressure decreases because you're losing all that protein, and your hydrostatic pressure increases secondary to the RAS dysregulation and the retention of sodium and water. You will also get hyperlipidemia as your liver says, hey, wait, our oncotic pressure is terrible because our albumin's so low, I got to make more lipoproteins. And because of that increase in lipoproteins, you'll start to urinate out fats, leading to fatty casts. You'll get hypocalcemia because as you lose your albumin, which is negatively charged, you'll start to lose calcium, as calcium is usually carried by albumin. And then you'll get infection. As you're losing your immunoglobulin and urinating that out, you're going to have a relative immunodeficiency, and it can lead to things like pneumonias. So I hope that was helpful. Let us know what questions, thoughts, comments you have down below. Again, feel free to hit that subscribe button and follow along if you feel inclined. And stay tuned for nephritic syndrome and then a comparison of nephritic and nephrotic syndrome. Thank you very much. Stay well. We'll see you next time.